are live and direct. Wow, what a great opportunity today to be live with our folks, fans, subscribers, followers all over the world. Welcome to If You Asked Jimmy. I'm really excited today because we are hosting a man of timber and caliber and a man of great repute. It's a privilege and my wondrous honor to have in the house today. Doctor, is my help getting too much?
No, I'm okay.
All right, so it's not a hype, guys. When you hear the profile of my guest today, you will understand why I have to celebrate him for being in our studios. As we are hosting no other person today than Dr. Adedayo Taiwo. Dr. Taiwo is a graduate of the College of Medicine, University of Lagos. Graduated way back 1997, is an alumni of the Trinity College, Dublin. Trinity, we'll call it in Nigeria, but because I'm in North America, Trinity, Doctor, Trinity College, Dublin. University College, Dublin as well, and is a member of the Royal College of Physicians of Ireland. He's an energetic, seasoned OB/GYN expert with more than 2 decades in caring and the provision of evidence-based and modern women's health care in a passionate and pragmatic manner. He's a highly honored, he's highly involved in management of dynamics of labor and delivery, early pregnancy complications, as well as gynecological abnormalities. He's a seasoned advocate of health screening for malignancies and lifestyle modifications. His experience cut across Africa. He practiced in Nigeria and Gambia before. He practiced in Europe, UK and Ireland, and in North America, that is Atlantic Canada, in the care of women. It promises to be an exciting one today. Welcome, Dr. Dayo Taiwo. Can you say hi to our viewers?
Hello, everyone. It's a pleasure to have me on this program. JJ, as I always call you, I'm delighted for what you're doing, and it's an honor to partake in it as well.
Absolutely.
For our viewers, I hope we have a good session throughout the first and the second segment of the program.
Absolutely, sir. Thank you very much. So, even if I wanted to hide our privacies by JJing me here, you're exposing me, but it's okay. Let's go there now. So from your profile, I read that I was smiling to myself. I'm not going to be mischievous about this, but there's a clause I saw that in the care of women, you are a seasoned OB/GYN expert. Can you tell us about what you really do as a medical doctor, and how long have you been practicing? You graduated since 1997. 97 to date is getting close to how many years now? Almost 30 years?
Yeah, almost 27 years thereabouts. So
what do you really do in your practice, medical practice?
After graduating from the College of Medicine, University of Lagos, Greater Cockaites, I did progress to Gambia for start. Primarily, I had a GP session, family medicine in Nigeria before moving out to Gambia. And Gambia was the beginning of my obstetrics input. I'll probably say I nursed the passion of doing obstetrics and gynecology for a number of reasons. I don't want to go into emotional aspect of it, but the idea of saying I want to save another person's death is what really kept me into obstetrics and gynecology. My mom died 4 months apparently when I qualified.
Wow.
And I probably think it's more of
sorry about that.
I won't go into the nitty-gritty of that, but looking back at it, having practiced in North America, you could probably say it's negligence, So going into that, that's what has driven me into the practice of obstetrics and gynecology. And apart from that, it's one of my best courses in the medical school. and it's pretty straightforward. It's demanding, but they're good. The good sides of it is really overwhelming. The beauty of delivery, seeing the pregnant women, beautiful ladies solving their abnormal problems such as abnormal bleeding, chronic pelvic pain, heavy menstrual bleeding. The arsenal of cases are, endless. And then the beauty and dynamics of delivery and labor and delivery. You're just happy that you're in that profession. Looking back, you probably say, "Oh, what else will I have done?" Maybe we get into that over time as the course
Wow.
progresses. So I would probably say it again. It was an inborn or innate passion to go into obstetrics and gynecology.
Wow. Doctor did it for us. Tell me that aspect you said that you probably go into it later. We have just go into it. Let's learn from your experience, sir.
Okay, I say we pretty much went into the same secondary school, and I'll probably say from there that in secondary school I was the Greek prefect.
Ooh,
A Greek prefect, and I did like farming, and that
right.
was what I had in my mind. But fortunately for me, I probably say my hands. I will always give kudos to her. She's still a living person, Mrs. Olayefun. The husband who told me, "Listen, it's either medicine or nothing. It's a strict. It was an order, a command. Medicine
Wow.
or nothing." So, and I mean, we are in a different world these days. We can't dictate that to our kids or our children. And I've
Right.
been told that, and you know how competitive things are in Nigeria.
Absolutely.
I probably say it's multifactorial in how I got into medicine ultimately. But I think it's a path that God has really, willed and destined me to be in. So I'm grateful for that, and I'm doing my bits and pieces in the care of women. People will probably say, "Okay, why did you go into women? Is it because they're beautiful?" Men are also handsome, but I mean, it's something I just cherish naturally. And each time I do the job, people look at you. "Why have you chosen this job?" I said, "Somebody has to do it."
Hmm.
So I'm in it, and we're doing fine, and God has been faithful and pretty good to us.
Amazing. Doctor, you really hacked it because, even though it's your professional practice, when it is women and you are a man, that gender thing, people will want to pick on you on that, but you have actually, nailed it very, very succinctly. And just so our viewers know, now that Doctor has exposed our background together, we have come a long way. We went to high school together way back almost like 40-ish years ago. And am I exaggerating? Like maybe 30 something, 38, thereabout.
Close to that, 1988, close to that.
Yeah. So, yeah,
86, 88, yeah.
yeah, maybe 37, 38 years ago. And if your uncle commanded, you see, if your uncle had commanded you to actually go into medicine, apart from you being obedient, the fact is that you had the capacity. We are, the A list of our students then, at least you are the brightest and the best. So, I mean,
I'll say
nobody can
one of. Don't praise me too much. I'm one
A
of the
list
bad.
now, D1, A list. A list means that you still have some people on the list, but you know that, of course, you were top ranging. So what I meant by that is that I wish my uncle had commanded me to do medicine. It would have frustrated me completely, But because you had
Yeah,
the capacity, you remember I was a science student, and it was
yeah.
just the final classes that I migrated to something different. I ended up in business today. So I celebrate the fact that you had the capacity to be a doctor and you are doing it to help humanity with all of the other reasons that got you into medicine. That's so much for talking about your career and the background of it. When you look, let's start from your professional practice in my other questions. How will you compare ancient and modern medical practice? I will talk about the orthodox first, but there's an opportunity I seize when I bring people to this program. There was a medical doctor who is also a pathologist, and parasitologist, a professor who was on this program last week, and we're able to gain from him, ancient and modern practice. So, but first, practice of medicine, orthodoxy right now, today and before. Is it the same in these days of computer, the days of AI and everything? How is it now, and when compared to when you started off in, the late 90s?
Okay, if you say ancient, I'd probably say when I started, it wasn't that ancient, though it's pretty almost my training was about almost 3 decades ago. So, but if we go into real ancient times and for looking at that word, ancient practice was pretty much using herbal, natural, medicine into making things, where most of what we do recently, maybe pharmacological medicine, are really evidence based. Those were just natural things. And there's
Okay.
still some people still believe in this. But if we go into the context of what we do and what we've trained in lately, anything you do must be scientific, research based, evidence. We are governed or guided by what we call guidelines. There are things that people have researched on. You can't just put out a drug now without the drug going through some level of testing, level of phases of testing, A, B, C, D, and probably you say, okay, this before it's put into circulation.
So,
Ordinary paracetamol, you know.
uh, compared to when you graduated from med school and now, is
Mhm.
it is it still the same?
Things are changing, but not overtly changing. It's like we probably say things are getting modernized, things are getting more scientific. People look into things. Patients even are aware of what they want. Before a patient comes to you, he or she has read about you. He knows what you're doing. He knows whether you're a patient person. So there's much more of awareness than
Okay.
communications again. So, and it now depends on the divide you are practicing. Are you in the Western or the developing world? Everyone has its pros and cons and the level of awareness. In the Western world, patients will ask you what they need to ask you. The 4W is, why are you doing this? When do you want to do this? What's the reason behind it? What are my options? But from where we are coming, that also exists, but the fear of our physicians is so huge back in Africa that people feel they always rate doctors to, if I may use the word, small g, small god. But
Mm,
over here, you will be see your colleagues, you relate with them freely. You discuss on the corridor. It doesn't need to be on the office. You'll be seeing your colleagues or your professor riding a bike or you in the bus stop, and you could initiate discussions around certain things. And if he's obliged to, he will discuss, but it will be freely. You're not worshiping them. You're not exalting them. You feel free to discuss things. So,
normal
uh,
conversations.
yeah,
Right.
solid one-on-one and robust conversations. Yeah.
Yeah, way back in Nigeria, people used to say something like laptop doctors because it got to a point in time where people will consult over the phone. And sometimes when you're consulting with some doctors, even in the course of treatment, they start referring to laptops, and it looks like a derogatory thing. Like it's like they are not really prepared, they don't know what they are doing. Have you heard that terminology, laptop doctors, and how does it really play?
I'll tell you what is going on recently now. I use this word, no man is an island. You can't know it all.
Right.
Okay. And when you are lost and when you need to make reference, it's a teamwork. Together, everybody achieves much.
No,
And
TA.
again, even when people look at you that you know it all,
Hmm.
we are in a profession that is very litigious. If you look at the field that is even most litigious, radiology, surgery, obstetrics, virtually every field is litigious, but you want to be cautious of what you're doing, what you're writing, what you make decisions because a lot is entrusted upon you. So, and you don't want to make it. Now we do what we call telemedicine. The advent of COVID brought a lot of things. And one of it was you can do things remotely, though you can't examine remotely in my own profession, but you can do some consultation to speed up or to be up to speed with the number of consultations we do. Most of these days, you think of one stop consultation. We want to see patients do pretty much everything under one stop or two. Not that you're lagging
So you're
behind or
saying that there
flapping
is
around.
nothing wrong with consulting digitally. I mean, like going online to look up some things. It doesn't mean the doctor is not prepared. Is that what you're saying?
Yeah, pretty much. I mean, you can make references. You can consult colleagues, but everything still rests within you to make a summary and a care plan for the patient and say, okay, this is what I'm
Okay.
telling you,
So
and this is
because
it. It doesn't
oh,
demean you, it doesn't demote you, and it doesn't make you to be short of knowledge or improperly trained making such things while dealing with a patient. But it's not most often, most of the time. It's probably a few times you could do that, you know.
all right. So because it looks like to us way back where we see that happen in Nigeria is like to us, it's like maybe the person is not prepared or being incompetent. Thank you for clarifying that for us. So let us take the two sides of things. Like we were original, we are Africans, right? And we
Yeah.
had our own means of healing and how will I put it now? Taking care of ourselves, the medical part of it. Now, many people believe because of modernity, they talk down on things that are African, that are original to us, and it looks as if the only option for us, we are only left, we are stuck with the Western medical practice. What will you say about that? Is it that everything that is ours, there's no value to them, or they are not potent, they are not effective, and our methods? Let me not even talk of methods. What would you say about the Africa, being an African yourself in Nigeria? What would you say? What's your experience, with what is ours and Western medicine? Is it that we didn't have anything good about our own?
The type of training I had, I'll make reference to that. The type of training I had toward the tail end of my final year, we did a lot of consultation of what is non-typically Western world white collar up medicine, and it's in order to make our training comprehensive and a good package. We had to go to what we call herbal medicine, herbal, I know how you call them, you know. We had to make some exchanges with them and see what they do in their practices and how we improve them. So, and we made it a few bits of correction here and there to them, but that was an idea for us to see how medicine goes, Now, regarding what we do, there are changes in how things are done now. And I've said that earlier. Medications, things that are natural, they might not be dose weighted, but at the end, the current medicine we're practicing, if you're talking pharmacology, if you're talking uh, technology, you want to see evidence of what you want to do. You want to quantify what you are giving in terms of medication, and that's what makes the difference. So, what we are trained back in Africa, we don't need to ignore them. Things go scientific and in special order. I mean, in a stepwise approach. So that's what I probably think. If I get your question right.
You really did. We can expatiate on it. That growing up, do you have experience or anyway, you practice most of your time outside the country. So I would have asked, but I'll still ask that does it, and you said you also went into to see what was going on the other side.
Yeah.
Were they providing solutions, even though you taught them maybe sterilizing and some other kind of things that make their practice safer, right? Dosage and other things. What is your own take on our trado, let's put it that way, our traditional medicine, our native intelligence as a people? Did we have solutions that were working for us before modernity set in?
I'll tell you in fairness that the current medicine we practice is a huge and far advancement in what is obtainable in the local setting. In low resource setting, people end up going there because of cost, finances, awareness, and you see the height of I'll talk in my field. Mortality, morbidity tends to be hugely high in those settings. Unlike now, if something where I practice both in Ireland and Canada, if someone dies, a lot of things will go on. There will be panels that will raised. even morbidities, a lot of meetings. Those are the academic. We still do that in Nigeria as well, and that's what makes the difference. You can't expect someone who is a herbal, doctor to be into context of doing all this. He wants to maximize his cost. He wants to do some other things, and they've tried. I said a scenario. You talk about breach. They will try their luck in delivering. You don't know the weight of the baby. You don't know how the baby is going to get stuck. Advantage of practice lately, you just go in there. Oh, it's a primate. I'm going to section this. 20 minutes, baby is in and out, and that's it.
All right.
And it doesn't mean you can't have 4 or 5 children in such ways. You can.
Wow, awesome. I think that you are able to answer my questions based on more on your specialization. And it is fully understandable because there are other maladies that could be remedied differently. And it could be a different experience with different practice areas. But in your own domain, of course, it is fully understandable that modern practices will really help because this is, women's care, childbirth, and all of those kind of things. And definitely, it's unarguably technology and modern practices would definitely make women safer and make deliveries easier and mortality rate as low as possible.